Large thrombus burden in STEMI, a case-based approach. A large proportion of patients with STEMI have suboptimal myocardial tissue perfusion despite recanalization of the epicardial vessel, the reasons being a large thrombus burden, and we are dealing with the prothrombotic milieu. There is no strong recommendation in the guidelines for the management of large thrombus burden. This is the thrombus grading all of us know, 0 to 5. The problems associated with large thrombus burden are distal embolization as well as retrograde embolization causing stroke. Distal embolization is what we fear the most. It causes no reflow, slow flow, poor myocardial blush, persistent LV function, increased arrhythmogenicity. What are the strategies to tackle thrombus burden? You have both pharmacological as well as mechanical strategies like thrombectomy and of course direct stenting, deferred stenting, so on and so forth. So the meta-analysis for mechanical thrombus aspiration in ST elevation MI has been not very encouraging, with the meta-analysis clearly showing that there is no merit in routinely doing thrombus aspiration in patients. There has been a downgrading of recommendation in the guidelines as years went by. So if you go through an algorithm for the treatment of intracoronary thrombus in the context of ST elevation myocardial infarction, if there is antegrade flow, if there is no antegrade flow, after wire passage, you assess the thrombus size. If the thrombus size is small, you can directly proceed with balloon angioplasty and stenting. If the thrombus size is very large, and look at the ongoing ischemia. If there is a large thrombus burden and there is no ongoing ischemia, you can afford to consider antithrombotic strategy and defer the stenting process. In contrast, if there is ongoing ischemia with a large thrombus burden, you can resort to thrombectomy strategies using mechanical thrombectomy devices aided by some of the other accessories like the angiojet or the ELCA laser if it is available, which is not available to most of us in our country, and then proceed with balloon angioplasty stenting. So this is a fair algorithm to approach patients with large thrombus burden. So we'll go through a few illustrative case examples as and when time permits, and revisit this algorithm to highlight a few case-based tailored approach. There is no one-size-fits-all when you deal with thrombus. It depends on a case-to-case basis depending on the pattern. Case 1 is a patient who presented with an inferior wall ST elevation MI who had an occluded right coronary artery. And after wire passage itself, there is establishment of antegrade flow. This is a sign of very minimal thrombus burden. After passing the guide wire, if the flow establishes like this, oftentimes you can get away with a stenting without much of a problem. So we proceeded with stent deployment, and we had a satisfactory result. So this belongs to a category of no antegrade flow. After wire passage, the thrombus burden is very small, so you can directly proceed with stenting. Going on to the next case example, again an inferior wall MI who presented a little late from the onset of symptoms. There was no post-MI angina. There was minimal regional wall motion abnormality. The LV function was preserved. So this was a very stable patient. And this is the diagnostic angiogram. There is some circumflex disease there. What is important is the right coronary artery is retrogradely filling. So it's a collateralized, occluded, infarct-related vessel. That is one of the reasons probably the patient is stable. And this patient has a very significant thrombus burden in the right coronary artery, as you can see in this frozen image. So significant filling defects in the right coronary artery. So here is a patient who is very stable, who has a distal RCA and PDA which is collateralized by the left coronary artery. There is significant thrombus burden in the infarct-related right coronary artery. There is a risk of distal embolization. So the PCA was deferred at this point. He was given a 24-hour infusion of tirofiban and he was taken up the next day. It is interesting to know that the thrombus has significantly reduced in the mid-RCA and only the lesion is restricted to the proximal RCA, and we proceeded with an angioplasty and a stent deployment with good results. So this is an example of a patient in whom there is a large thrombus burden. However, there is no ongoing ischemia. And so you can refer to, you can defer the stenting. This is a deferred stent approach. Moving on to the third case example, a 42-year-old male who presented again with an inferior ST elevation myocardial infarction. You can see the extensive thrombus burden in the right coronary artery. So this patient, we did a thrombus aspiration. I'll just go through these slides a little faster. And there was significant removal of the thrombus. And this is the result after thrombus aspiration itself, a stent-like result. So here, you can afford not to stent because you have a stent-like result in this patient. So you can do a standalone thrombectomy. This is particularly true for patients who present with a plaque erosion rather than a plaque rupture. The last case example, a 48-year-old male with a vasculitic disease with a past history of DVT, pulmonary embolism, who presented with an anterior wall myocardial infarction. And you can see that there is significant thrombus burden in the left anterior descending artery with hardly any antegrade flow. And this is wiring. And after balloon dilatation, there was no resumption of antegrade flow. Again, we did a mechanical thrombus aspiration here. And after thrombus aspiration, the flow improved in the vessel and we proceeded to stent this vessel. So here is an example of a patient with a large thrombus burden where we did a mechanical thrombectomy followed by a stenting because there was significant residual stenosis. So this is an example of no antegrade flow, and after wire passage there is a large thrombus burden, ongoing ischemia, and so we did a mechanical thrombectomy followed by a stenting. If there is a need, you can always give intracoronary lytics or intracoronary glycoprotein antagonists in these patients before we venture into stenting to establish good antegrade flow. So it's important to prevent thrombus by pharmacological pre-treatment, and this we have already enlisted. I want to stress the fact that intracoronary glycoprotein antagonists and intracoronary thrombolytics, though it's very attractive, the data is not very strong. You have to decide on a case-to-case basis. And this is the list of medical management for managing no reflow phenomenon. So I'll conclude by saying that thrombus is an issue that we deal with most patients with ST elevation myocardial infarction. In patients with a large thrombus burden, the consequences of no reflow can be deleterious with compromise of LV function, arrhythmias, and even death. The recommendations to treat thrombus per se is not very strong in the guidelines. Adjuvant treatment options are helpful in patients with large thrombus burden, like for example mechanical thrombus aspiration, intracoronary glycoprotein antagonists, intracoronary lytics, so on and so forth. These options need to be selected on a case-to-case basis and not one size fits all approach. Thank you for your kind attention.